Hi, everyone. Welcome to our Thursday webinar series. We are happy that you have joined us today. My name is Lourdes, and I would like to introduce our speaker. Dr. Midun Malla is an associate professor of medicine at the Heer Singh School of Medicine and serves as a section chief of gastrointestinal medical oncology at the O'Neill Comprehensive Cancer Center, University of Alabama, at Birmingham in Birmingham, Alabama. He subspecializes in the medical treatment of gastrointestinal malignancies, and his research focus is on hepatobiliary and colorectal cancers, with a strong emphasis on improving outcomes through precision oncology. Dr. Malla leads multiple prospective investigator-initiated clinical trials and is nationally recognized for his work in circulating tumor DNA, or ctDNA, with key publications in the Journal of Clinical Oncology. He is excited to join the webinar to discuss personalized approaches to help tailor treatment strategies in managing patients with bile duct cancer. Thank you for being here today.
All right. Well, thanks so much, Lourdes, for the kind introduction. Hi, everybody. It's always a great pleasure and honor for me to be, involved with Cholangiocarcinoma Foundation and doing educational webinar teaching activities. It's something that I connected with my heart a long time ago, and I continue to do those, especially in the realm of personalized management of malignancies. I think it's really, really important that we individualize treatments to individual patient, because everybody's different. Everybody's cancer is different. One size may not fit everybody, right? So I think in the same realm of conversations, so today let's delve deeper into the circulating tumor DNA and how that can help, and how do I use it in my practice as a personalized methodology, especially in cholangiocarcinoma. All right, you already met the presenter. So let's see what we're going to cover today. So we're going to start with introduction to the cancer monitoring tools. I think that includes circulating tumor DNA as well. And then followed by how the circulating tumor DNA, which we'll be calling as ctDNA, for MRD detection, which is what we call molecular residual disease, also called the presence of cancer cell detections that we could detect in the blood. And how can this tool be useful for patients with bile duct cancers? Now, clearly, knowing how cells shed this circulating tumor DNA is really important. One thing I always tell my patients in my practice is, let's say if they underwent a surgery for cholangiocarcinoma, come to talk to me about, in the next treatments. One of the common questions that I get asked is, Dr. Malla, I had my surgery. My surgeon told me they got it all. Why would I need any more therapy? And the clear rationale for that is the cancer cells are so tiny. We also call microscopic, like really hard to see with the naked eye. And these cells, they break down regarding different phases of treatment, be it surgery or any treatment, like per se, in the management aspect. And there could be residual cancer cells lingering in the body, either circulating that we don't know, maybe in the tissue that was removed. And for a long time, we had this challenge of, can we even detect it, right? Because if you're able to detect it, then we could, identify approaches of how to perhaps handle it and how to perhaps, change management. So I think these are, tumor, obviously this is macroscopic, which is look by the naked eye or pretty big, but then these are the cells that circulate. I mean, they have the DNA in it. And by testing it, it can potentially test and look for a molecular residual disease, what we call as anything that's residual or remaining in the body. And because that has been shown to identify relapse, meaning cancer coming back much earlier. So there are different terminologies. I'm not going to delve into much of those depth here to confuse you, but for the sake of discussion, we'll go with circulating tumor DNA. Is just a piece of the DNA that is shed from the tumor cells. Now, what is this molecular residual disease? It is just going along with our discussion, like presence of this very small traces of cancer in the blood, such as ctDNA, right? And that happens when the cancer cells die. I mean, cancer cells, they keep building new cells, breaking down, and in that process, some of the old cells they die and they release the DNA, or they're dead for also reasons because of some treatments like radiation, chemotherapy, whatever, or the shedding. They keep shedding as well. And those are the ones we detect in the blood, and if that can help potentially some management options. So today we're going to be talking about specifically a tumor-informed approach, which I'll talk in a minute, and is more personalized. And why is it a tumor-informed, right? Because of the fact that we're sequencing tumor tissue of the individual patient and to understand the unique set of tumor variants in it by the genes. Every tumor or cancer has a certain signature of genes, and then there is custom designed assays for each patient to identify the top ranked tumor variants or tumor genes that could be identified and potentially can help in monitoring the disease. And that's what this work has done through Signatera, who is leading the tumor-informed testing currently. So it is personalized because it's taking the tumor signature from the own individual patient, and then perhaps doing this testing in the blood, the same sequencing to repeat it, and gave us the results as either it is ctDNA positive or ctDNA negative. So, this is how the test report is generated. The test usually is reported as MTM per ml, which is presence of number of tumor molecules per ml of blood collected. And it is given quantified in terms of, for example, this patient had in January about 48 cells per ml, but with treatments by April of 2021 came down to 0.00. So this is how it could help in terms of longitudinally following for the same patient with the treatments we provide in terms of responses. So this is similar to the tumor marker, like the CA19-9, the CEA, but perhaps more sensitive, more specific tumor marker, especially when checked in multiple settings because it is more tumor informed. So as it says on the left, it says, you can track how your cancer is responding to therapy. After surgery, you could check for if any remaining cancer left after therapy, whether you could detect recurrence early before it may show up on the scans. It really provides that additional guidance for the treating physician and having those conversations with the patient in terms of, how closely to monitor patient. And that goes in line with this slide here is, who benefits from personalized monitoring? Because if I have two patients, one with ctDNA negative, one with ctDNA positive, the ones who are ctDNA positive, knowing that their risk of recurrence is high, I would perhaps suggest them to get scans at sooner intervals rather than in those patients who have ctDNA negative persistently, the risk of recurrence has been shown to be low. But again, it's really important to stress the fact that ctDNA should be taken in the context of the whole picture, not just exclusively by itself, because it's important to identify the cancer pathology tissue and how aggressive it is, identify scans, identify the tumor markers, identify ctDNA, put everything into perspective. But certainly, this is one of those personalized testing that can help, who needs closer surveillance, who rather can wait a little longer. It can also help detect relapse earlier than the standard of care tools, where what it means is like the CT scans. Is my cancer coming back? Really is the important question always. My patients ask me in clinic is after the surgery, after the treatment, in terms of, hey, how do you measuring what is my risk of recurrence, and how do we tackle that? And in those patients who are already receiving therapy, circulating tumor DNA in a different platform can help in terms of if the treatment is working, whether it is shrinking the tumor cells or shrinking that gene variant, and to help in that aspect. So honestly, I think there are a lot of unmet needs within GI cancer management, starting from the continuum of care, like in terms of even before the surgery, which is called the neoadjuvant, and post-surgical MRD assessment and recurrence in terms of once whether the cancer is going to come back or not. And then if they're on treatment, how is the treatment responding? So across the care, there's still a lot of unmet needs. I think ctDNA, can help bridge some of that unmet need here. It can help assess the effectiveness of neoadjuvant therapy. If it is the levels are going down with therapy, it could help predict which patients will, perhaps are at a higher risk for recurrence, and that way we could help, talk to them more personalized as way of things. And monitoring ctDNA can detect early relapse, clarifying, the indeterminate findings. For example, I see commonly if my patient, smokes cigarettes every day, their CEA is going to be high. And they're also in cancer surveillance and you're checking CEA, it is abnormally elevated. If they have like colitis or, cholecystitis, the CEA is going to be higher, tumor markers are high. So that's where I think this helps in terms of giving more sensitivity, specificity to help really guide us. So now, as we talked about, every person's cancer is unique as their fingerprint, and Signatera is so personalized that can custom design those to help in a real world. So the way it works, I think we talked briefly. I'll go through this relatively quick. So it's a one-time analysis of the tissue. So it really needs your tissue sample for the first time, along with the blood. And once it is built, moving forward, doesn't need tissue anymore because the signature is already built, and using that signature, it continues to be checked in the blood and testing results are provided. The first time point testing takes about 4 weeks, the results to come back, but then afterwards, from the time they receive the tissue, but afterwards, about 7 to 10 days in terms of the turnaround time for testing. So understanding your results, like let's say you had a negative result, which is like ctDNA not detected. Again, I tell my patients clearly, ctDNA not detected means ctDNA 0.00 is to the best of the ability of the testing mechanism we have, it is undetectable. That doesn't mean they don't have it, but it is really good enough to tell us that the risk of recurrence for more negatives or more undetectable tests is risk of recurrence is quite low. So no tumor DNA was found, whereas positive result is, more confidently you could say that it means the tumor DNA was found in your blood. It's almost close to 95 to 99% in terms of the cancer could come back. That's how significant the positive result is. So we talked about this. We will skip this slide. And then how long? I think we also covered the 3 to 4 weeks and 7 to 10 days once your signature has been set up. The testing, there's also options. I think one of the things that I really like about is there is an option of home phlebotomy. So once I see the patient in my clinic, the individual, and we collect the first testing and coordinate the tissue being sent, to the company for testing, they could help with home phlebotomy. So, and the cadence is really patient specific. So if I'm really worried about a patient who I want to check it like every 2 months, then 3 months, very supportive. Obviously, I talk to my patient to make sure I get the consent in terms of they would like to get the testing done, but it really helps. And I also like to check the testing couple of weeks before their next follow-up appointment. So that way I have the results for me to talk to my patients when they come to see me. It's more of a comprehensive visit to help in terms of getting their labs, potentially scans, plus or minus, and the ctDNA and their clinical presentation overall. So what to expect? I think, there's somebody that can call a coordinator or call you. Provider is managing your blood. They will connect with you about the blood draw, and then the blood draw kit will be shipped to the home. You could either bring the kit with you to the appointment or save the kit. So because as a mobile phlebotomist comes to the home, they could help draw that for you. And this is how the kit, looks like. It does contain blood tubes, 2 blood tubes actually. There's some gel pack for the blood, and there is paperwork, of course, that we help fill it in. Or we have fantastic nurses who complete that process. And then the kit temperature should be stored. You don't have to worry about it much. But these are some of the important things, about the kit in general. Now, with that information, let's delve into tumor-informed MRD testing and the technological overview. Okay, I'm just checking the chat to make sure there are no questions. Let me see if the tumor. Okay, so let's address the question, I guess, here. This may be well covered later, but my question is how useful ctDNA is once a patient has begun chemotherapy. This might be an option where the initial biopsy did not contain sufficient material for mutation analysis and standard of care treatment has commenced. So that's a really good question. Since this is more tumor informed, as I was specifically talking about Signatera, it goes back to the tissue. So we could still go back. I mean, I think, can use it even in my practice if I see second, third opinion patients, especially it's more applicable. So go back and check that tissue for sufficient material. But if the biopsy doesn't contain sufficient material, I think that's going to be tricky because, they need at least 200 cells to evaluate and provide a good signature for the patient. So that's something, it's important. And that brings a really important question and a point that biliary tract cancers, not all the time, we have the tissue. So tissue can be an issue. So that's an important point and discuss with your provider. If the tissue sample was taken from metastatic tumor rather than the original tumor, will the Signatera results still be accurate? Absolutely, right? I mean, so sometimes I think most of my times in my practice, I like to use the metastatic tissue, but it's also important like why we are testing that for, right? Because, if I have a patient who's oligometastasis, who is like, perhaps 2, 3 or 4 tumors, and then we have a biopsy from the metastases, the goal is still be aggressive, trying to potentially get to surgery, but might also use Signatera to help in tracking the levels to see how the response is. That might be a great example where we could use the metastatic tissue to predict the recurrence. To predict the responses. And once the surgery is completed, potentially to use it as a molecular residual disease test and also to monitor as we keep going along. So then do the results just report in a binary form, presence or absence, or they do provide a more detailed, more than just a yes or no? I think, let me go back to one of the slides here. So this is how the result is generated for that question. It's more of binary. So negative, positive. If it is negative, there's not much detail mentioned as 0.00, but the same patient who had it positive, so if it's positive, they give a numerical value. Because it is a quantifiable value, that's something, we follow along, numerically to assess the number of cancer cells and how they're shrinking or how they're responding to therapy. All right. Yeah, let's get the questions going. I like the questions there. One thing I always say is, the patients within the CCF team and those join those meetings, they're quite knowledgeable, ask fantastic questions. So please get them going. We'll delve into the tumor-informed MRD testing here, more of technological overview. So this is something we talked previously briefly. So clinical applications. So it can be utilized pre-surgery, like prior to surgery. That's always the ideal time to even get it if you have enough tissue, because that time the patient takes to go for surgery anyway, that would be helped in terms of utilizing that time to perform the testing and the results to be generated. But if I'm treating a patient with intent of surgery 3 to 4 months down the line, I may still get it because that helps me monitor the response. And then following surgery, which patients are more likely to relapse, and then to detect relapse earlier than standard of care tools, which are scans, and then eventually, if they relapse, like to assess treatment response. Now, let's actually go into a patient case because it's always more relatable as we talk about a patient, and this is actually one of the patients that I've treated. A 73-year-old female presented with abdominal pain and some non-specific symptoms, and further workup demonstrated a mass within the liver, and she underwent a biopsy. It turned out to be a poorly differentiated, which is like little aggressive type of a tumor, uh, originating from the bile ducts within the liver, which is intrahepatic cholangiocarcinoma. So it was staged PT3 and X because the lymph nodes were not, removed completely during the surgery, and then no evidence of metastases. She underwent left hepatectomy, extrahepatic bile duct resection, and as standard of care, went ahead with 8 cycles of adjuvant, which is after surgery, Xeloda, which is like the 5-FU, but the oral formulation of it. 8 cycles is almost 6 months because each cycle is 3 weeks with the oral pill, and that's the standard of care, right? And then after the treatment, generally, we initiate the surveillance, which includes seeing the patient, the individual every 3 to 6 months, scans at a regular basis, CA19-9 during every visit, and then I like to include circulating tumor DNA testing in the surveillance setting. So, and now, before we move on, I also wanted to specifically talk about what is the data, right? I mean, I keep talking about I like to use it. I like to use it, not because I just like to use it because I just like to. I think there is a lot of data, to support that checking it, and if it is positive, it does have a prognostic implication, which is those patients who are negative as positive, there is significant difference in impact of survival. So on your left top corner, MRD, which is molecular residual disease, which is after surgery, within up to 12 weeks after surgery, positive versus negative. Entire slide, positive is blue, negative is green. You can clearly see that green is top, blue is bottom, because the disease-free survival is on the left-hand corner. So those patients, these are all the patients in the study, like about 67 patients here. Like they're doing much better in terms of survival compared to those who are not detected. What does this hazard ratio 1.8 mean? So patients who are positive for ctDNA, their risk of recurrence is going to be that times higher compared to the ones who do not have positivity. So anytime post-surgery, so this is even beyond 12 weeks, the curves even separate, as you can see, and look at that number goes to 3.81. And then 12 weeks after cycle 1, day 1 of therapy, that curves even further separate. And 24 weeks, which is 6 months after cycle 1, day 1, which is you're completing the adjuvant therapy, the curves separate as well. So although the numbers are 60, 40, 70 patients, we're talking about not a common, cancer, but still, the data is really building up. And actually, we do have more than 150, sample size data that is currently being in the process of, reviewed for publication. So once that's out, hopefully, I'd like to come back and share that data as well. But, it's looking strong, right? and really, when we did this analysis, we tried to look at ctDNA compared to the tumor markers commonly checked, CA19-9, CEA, which one is better prognostic tool for relapse-free survival, meaning the amount of time an individual can live without cancer coming back. That's the relapse-free survival. And clearly, ctDNA is the winner, right? During the MRD window, during the surveillance window, during, and if you look at the CA99, which is in the bottom, you see the curves are so much overlapping on top of each other, and the p-value is 0.51, meaning it is not strongly significant, whereas CEA is also not strongly significant. So I think this is very clearly established that ctDNA is much better biomarker to use for prognostic testing for our patients with cholangiocarcinoma. Depends on the individual setting. So that's quite clear here as established. But I would still check both tumor markers and ctDNA in my practice. Now, going back to our patient that I talked about here again, to revisit, 73-year-old, underwent left hepatectomy or surgery for her cholangiocarcinoma, found to have a T3 type of a tumor, and 8 cycles completed adjuvant Xeloda. Now, how did MRD testing inform her treatment plan? So this has been the trend of her circulating tumor DNA testing. So the first time point after surgery and also after completion of adjuvant chemotherapy, she has 0.00. This is the first time point of scans, no evidence of disease, and she continued to be monitored in a 3-month cadence. In the initial aspect, post-operatively, especially, she's also poorly differentiated. I usually try to opt in scans every 3 to 6 months to help, because of the risk of recurrence, and also follow NCCN guidelines. After a few negative CT scans and few negative circulating tumor DNA testing, I started to move the CT scans, every other testing. So me keeping ctDNA here, that also is negative. And then the 5th time point testing continued to stay negative, and the CT scan was also negative. NED means no evidence of disease. But the 3 months later, slowly we started seeing some circulating tumor DNA positivity. What I usually do is try to repeat the testing, and we can see slowly going up as well. That's when I've ordered another CT scan, and my patient had no evidence of disease again. But this is when I was talking, earlier in terms of how do I modify my scans and surveillance and type of scans. That's when I changed the modality of scans, either get an MRI or a PET CT scan. So I followed the CT scan the next time in a couple of months with a PET CT. The ctDNA was doing its dynamics. I mean, it goes up and maybe going down a little bit. She was not on any treatment, but we did the PET CT scan, and we, found some evidence that may guide us in the right direction. So after the PET CT scan was performed, I'll go back to this slide. We actually found some activity right at the area of surgery. So she underwent the surgery, in the liver area, and there was some activity. I presented her in the tumor board, and we came with the consensus to potentially do an endoscopy and try to identify the location, because it is active on the scans. And guess what? When we went ahead and did the endoscopy, we were able to get a biopsy. Thanks to our advanced endoscopy team, we're able to identify biopsy positive for cancer just in the site of cancer, surgery. So that really helped, in terms of now that we have a biopsy proven cancer, I think I could intervene in terms of treatment, because just based on ctDNA, we're not yet ready to change treatments. This is something I want you to take home really is, if the ctDNA is going up, doesn't mean you have to change your treatments, you have to start new treatment, but it's very important to identify where the cancer is so we could act accordingly, like what we did, in this scenario. So with that findings, I've discussed, with my patient here in terms of, hey, how about we start you on some sort of therapy to help control the cancer cells, starting with chemotherapy, with main focus of chemoradiation therapy. So hindsight, when we look back in the pathology tissue in the surgery, there was a posterior margin that was positive. So whether that was the reason why she had cancer cells detected exclusive at the site of surgery, possible. So we also thought about augmenting that with chemoradiation. So as soon as I started my patient on gemcitabine capecitabine for a few treatments, that went back down to 0. And then we added chemoradiation therapy. It completely, became 0. And the CT scan, no evidence of disease. And the ctDNA, also no evidence of molecular disease we could identify. And I mean, we stopped at like the 14th cadence. I think she had multiple testing beyond that, and stayed negative for a good long time. So one of the experiences that I would like to share always, in terms of how it could be used in real time to help guide our treatment patterns, right? So with that, go with the next, set of slides here is mainly shared decision making. So for this, going ahead with along with the discussion of the patient and the clinic, how do I present the testing to my patient, right? So when I see them in my clinic, I talk to them about the standard of care testing, which is blood workup, the tumor markers, CT scans. Along with those, I also present the option of, hey, there is a personalized way we could monitor your cancer, which is circulating tumor DNA. And this is how we could do it. Send the tissue along with your blood, which we could collect today and send it to the company. It's it's if they're in the post-surgical testing and I talk to them, hey, we're gonna do this chemotherapy regardless, but this is hopefully can help monitor the cancer recurrence and present that option. And again, this is a shared decision making. Everybody would like to do things a little different. Most of my patients would want to go have the testing, and some patients are, what, I just would not want to do this. I completely respect that, and that's something always has on discussion between patient and your provider, right? So and knowing this testing helps always in terms of asking the clinician that you see is if it is right for you. They may not be there in all scenarios that it is right, but most of the scenarios it is applicable to help out. And why? Because there is wealth of peer-reviewed research. So there is evidence of ctDNA across cancers in over 150 peer-reviewed publications, and this continues to grow. So there is a lot of evidence there, but what we need further is, if it is positive, can we change treatments just based on positivity, or can we do more personalized therapy? The field is still trying to work and figure out what's the right mechanisms, and Natera is leading in that environment, trying to do studies in that aspect, but it really helps in terms of how to monitor the disease. And I think this is one of my favorites here, patient education and resources. So you could scan this QR code to help find out how MRD research is shaping GI cancer care, what is the difference between MRD testing versus traditional cancer monitoring, any questions, patient portal 101, improved patient access, and so on and so forth. And it's always a lot of helpful information. So I think we're nearing the end of the talk, and look forward to having engaging conversations hereafter. So key takeaways, it's Signatera, tumor-informed testing, and because it's tumor-informed, it is personalized. And it can determine if there are signs of cancer remaining in an individual patient after surgery or initial treatment, and whether a patient would benefit from additional therapy to improve their outcomes, and if the treatment is working by tracking their disease burden through serial testing, and if the cancer is perhaps returning by detecting relapse earlier than standard of care tools. And when used serially, which means on a continuum of basis, like regularly every 3 months or so, along with other tools, it may provide additional insight into guided shared decision making. And at the end of the day, the decisions that I make are by keeping patient in the center, right? My job is always to ensure that I provide a lot of knowledge during their visit, and it is make them empower to make the decisions. And I think it's going to be a patient-centric mission in that aspect, right, to make them the decision. But to go along with that, there is access via Medicare coverage, compassionate care programs, mobile phlebotomy, and a dedicated customer service experience team. So with that, I think I would like to keep this slide maybe open, and let's open it up for questions.
Thank you, Dr. Mala. Yes, as a reminder to everyone who's on, please enter your questions into the chat or the Q&A, and remember to please make them general in nature, as Dr. Mala can't answer your very specific medical questions. We do have quite a few already. Someone is asking if they're curious about patient access. Is a test widely available now? Do you know if it's available
It is.
pretty
It
much
is. It
everywhere?
is available. It is available. I think there's a lot of familiarity. I think it is. It is quite available almost everywhere in the US, to the best of my knowledge.
Okay. Can this test be used back at the early detection stage if cancer is suspected in a patient?
Oh, I see. Good question. So cancer is suspected, but we have not diagnosed a cancer yet. But can this be used to detect a cancer? This test, as of today, the specific test, no. This is mainly because reason is this is a tumor-informed assay, meaning an individual need to have a tissue, cancer-proven tissue, to provide this testing result. And in somebody who do not have a cancer but high risk, there is unfortunately no utility of this testing here. There are other research being performed in that setting, but this, I know, to answer your question, I would not use it.
Okay, thank you. After several types of treatment over the years of time, can the tumor DNA change, making another tissue biopsy necessary?
I really like that question. Especially if you're talking about cholangiocarcinoma, it is so important to watch this testing in real time, because there is about 30 to 40% of patients with cholangiocarcinoma have genetic alterations, and we're able to identify them by doing circulating tumor DNA testing, either to tumor informed, tumor uninformed. But regardless, I think we have opportunities to follow those testing while all our patients are on therapy, to help identify any new mutations as they're developing, or there is response to therapy. And to answer your question, yes, cancer cells are so smart, and they could develop mutations as one cancer is exposed to a certain type of drug. you know Identifying them can help in a certain proportion of patients. Still, there is a big bucket of patients which we still don't know by testing them regularly in terms of what to do, what not to. So this is an ongoing research, but really helps personalize the testing in practice.
Okay. In relapse, does it most of the time have the same ctDNA as before it was resected, or can a new tumor evade the Natera test because its ctDNA variated from the originally sequenced tumor?
So to repeat the question, say if a patient underwent a surgery and been on surveillance, and maybe at some point you're seeing the ctDNA being detected, is this the same cancer or is this something else? So especially with this testing, because the tumor-informed assay is performed on the original testing of the surgical tissue, assuming if you're able to detect them in the blood, probably an year or two later, for example, in my patient, almost an year and a half or so later, we're able to detect it. It is definitely related to the tumor that was resected, because that's how it is, tested and performed, right? So yes, in those cases, I would go with management depending upon scans and location of tissue, and also the way the ctDNA testing is performed by Signatera is they identify the top high variants. It's also called passenger mutations, and these are quite unique, and they are present in the journey if they're detected in the blood in general. So the tend to have variations in those is limited, but something that they have really cool mechanism in terms of following that along during the treatment course.
Okay. Can a Caris sample be used to establish the baseline?
So I think further information is required in the question for me to answer it. I don't know what baseline is inferred to here. So So I can't answer that question because of that.
No problem. Thank you. A Natera signature test can be positive due to the presence of circulating tumor DNA of dead cells due to treatments such as radiation Y90 and others, and not necessarily because a cancer is returning or the treatment is failing. Is that correct to say?
So let me understand that question is because due to the treatment such as radiation Y90 and not necessarily because the cancer is returning. A positive ctDNA test has quite a strong predictive value for cancer to come back. So if I see a positive test, it's like less than 1% of the cases in my experience, and also with the data we have, is has the risk of cancer not coming back. So I would take that very seriously if it is positive. If it is negative, there are chances of this testing missing the cancer in the blood. Okay. So that's really important to differentiate, and hence negative test I like to continue to check to make sure that there are multiple negatives, because 5 negatives are much better than 1 negative in telling me and my patient and answering the fact that the risk of cancer recurrence is low. Whereas 1 positive is very good enough for me that the risk of recurrence is high, if that helps answer the question.
Thank you. How often should the Signatera test be repeated?
So I'll be very honest here. There is no guidelines here. They're not currently in the NCCN guidelines as well. I mean, you could, it's there. The cadence is there, but usually I like to check it every 3 months, especially in terms of frequency. That's what I meant for the guidance. But I like to check it every 3 months, especially within the first 2 to 3 years after their cancer surgery, given the risk of recurrence can be high. And that's going to be an ongoing conversation with my patient. If they're like 2 to 3 years out and if the cancer is not shown to come back, I'll have conversations at that point saying, would you want to push it every 6 months and just continue the monitoring? So it's just individualized. And then let's say, for example, if I had the patient who has poorly differentiated tumor, positive margins, high Ki67, and those high risk for recurrence, I may actually do less than 3 months, maybe every 8 weeks as well. And if I see a tiny positive, I like to repeat that as well to make sure if it is, again, positive to ensure. So there are different ways of doing it, but for the most part, I like to do it every 3 months.
Okay, thank you. How long after surgery can the initial ctDNA testing be completed for ongoing monitoring and comparison?
Yeah, so very practical question. I would give a good 2 weeks at least, if not 4, for the initial testing. There have been studies that are performed that there is a component of normal cell DNA and cancer cell DNA within the first 2 weeks, even 2 to 4 weeks after surgery. There may be some mix of normal cells and the cancer cell DNA, but that studies have already been done in GI cancers. So if I, depending upon when I see my patient, but if I see them within the 2 to 4 week window, I would go ahead and start the first testing. And that result will take about 4 to 6 weeks to result after I send the tissue, about 4 weeks maybe. And then ever since then, I just keep doing every 3 months cadence.
Perfect, thank you. Can you explain again the difference between tumor markers and ctDNA?
Yeah, absolutely. So tumor markers that have been there, also in the guidelines and continue to check, are something, are secreted by the tumor, and they're in the blood. But sometimes they're non-specific. As I said, smoking is an example. Inflammation, infection could lead to, or any mucositis damage to the GI tract could lead to those markers going up. So whereas ctDNA is specifically coming from the tumor. So that's the difference in terms of where is the origin and how sensitive and specific. Tumor markers are decent in terms of identifying, the presence of disease sometimes, but not all the time, right? I think this is where ctDNA is more personalized in terms of helping. There, I have patients actually who are tumor markers are positive, but ctDNA is negative. For various reasons, it could be.
Okay. Can you maybe explain a little bit as to why the Natera testing levels may go up and down rather than going in a single direction?
So, right, yeah. So there are a few rationales for that, right? I mean, it depends upon the tumor shed rate. There are some tumors which shed quite commonly. If you look at colorectal cancers, they are common shedders, right? And this is where I think Natera has tremendous amount of data. And also within individual cancers too, some cancers divide quite fast, and those are fast shedders. Some don't divide as much and might not be as fast shedding. So the levels that are detected is pretty much related to what was the level of that cancer circulating marker in the blood at that time point. And another difference I think I also want to make between the tumor marker and the ctDNA is the half-life, meaning if I have a patient, if I draw ctDNA and CA19-9 tumor marker at the same time, the ctDNA is a representation of the same day blood value, whereas the CA19-9 is perhaps a few days before because of the half-life as well. And something half-life is nothing but how long does it take for number of cancer cells to go low, like 50% and then further. So that's ctDNA is more accurate in that aspect. And why does that fluctuate? It depends on the tumor shed rate, like how often the tumor shed the ctDNA.
Okay. We've had a couple of questions come in from folks asking if this is covered by insurance. I don't know if you know this, Dr. Mala, or if our friends from Natera might be able to jump in to answer that question and the price of the test.
In terms of the coverage, I could help answer, provide my experience, but I'll leave the other questions, for sure, the other aspect to Signatera folks. My experience has been depends on the insurance. So some do, some may not. But one thing, and also that supports me in terms of why I use it in my practice is commonly is because of the support that provided by Natera. For example, if I test one of my patients with this and insurance comes back and says it is not covered, we're not gonna cover this, and then Natera steps in and helps take care of that for the patient, right? Yes, they may get a bill to the home, but I reassure them saying like, you don't owe anything to the insurance or the company, it gets taken care of. And also that's from my personal experience for one of my family members, so I could relate to that. But is there anything else to add from Natera team?
No, Dr. Mala mentioned actually great information. As Dr. Mala said, there is a possibility that the insurance will reject the claim, but Natera is not going to bill the patients. And also Kelly from our team, they provided a very helpful link. So we actually encourage everyone to take a look at specific resources, but long story short, the patients are not going to bill about this test. We're in the process of submitting Medicare coverage, but as of now, Natera is covering the test for the patients.
Thank you. And in that same vein, I suppose, do you believe this will become a standard of care for cholangiocarcinoma patients using this test?
I'm personally biased. So if you ask me the question, I would probably say, if someone who would like to manage patients more personalized, I think it will likely, I think what's more important on us as researchers is to show more data, like more support saying like, if you're doing the testing, what else can we do differently for our patient? And more research is ongoing, but we are currently working diligently in terms of publishing the data that's already existing, and doing that work. So that's more to come on there, but I'm inclined towards, I use it as quote unquote standard of care in my practice, and I hope and it will become one in the future.
Okay. Does this test show resistance that develops if you are on a FGFR inhibitor drug?
This is one question I think I was really impressed about and wanted to answer this even if you don't have time, but I'm glad we have time to cover it. But one thing, want to piggyback on the topic we talked about. So Natera test is mainly saying positive or negative, right? That's the tumor-informed test we talked about today. So it's not going to say what FGFR resistance that an individual has if they're on FGFR inhibitor therapy. So for that aspect, there are other assays that could potentially be used in terms of looking in the blood and trying to detect longitudinally in terms of development of mutations. So to answer your questions, this test, no.
Okay, thank you. Does an increase in ctDNA always mean the cancer is growing, or can different somatic mutations cause the increase?
So it's commonly, positive test suggests to me that there is, likely cancer recurrence. As I said, the strong positive predictive value is greater than 90%. That tells me more than 90% of the times, if I have a positive test, meaning that there is cancer growing or cancer coming up, or the cancer cells are cooking in the blood. So it just gives us information ahead of the time to use it in the practice. And one thing I also plug in and why I use it in my practice, especially in those scenarios, is by checking ahead of the time, by identifying ahead of the time, like the patient that I talked about, we still can offer quote unquote therapies that can offer cure to the patient. Like, for example, if my same patient had a small spot in the liver, but we were being proactive in checking this testing, that's someone that maybe I could talk to the surgeon again to see whether we could either cut it out or burn it with ablation. So that's, the help that we could get. And in terms of clinical practice and doing more personalized therapies and saving the time of chemotherapy. I mean, these treatments of chemo we have, they're good, but they're left with side effects. So perhaps you could provide longer time of those therapies by doing this local therapies, depending upon where the cancer occurs.
Okay. So going back to the person who asked about the KERAS being used as a baseline, this is their follow-up. If a KERAS analysis has been done on the tumor sample identifying ctDNA, can that result be used for the follow-up blood testing?
So yeah, now it makes a little more, I think I can follow it better. Thanks for clarifying it. So if the question is if that was done on the tumor sample identifying ctDNA, so I mean, can that be used for follow-up blood testing? I would like to see more data from that scope of testing to identify whether we could use that to follow up. I usually use Signatera, especially because they have the richest data, more strong data, at least in the current field.
Okay. And then is this test recommended for patients regardless of their staging? So anyone can use it?
In my practice, I like to limit the usage for stage 4 cholangiocarcinoma. For my stage 1, 2, and 3, most of the times I talk to my patients and make those decisions. For stage 4, if it is somebody who has widespread stage 4 disease, Signatera's at that point, you can use it if you're using immunotherapy to help monitor the response. But, for example, if the same patient had an FGFR or an IDH2 or a HER2 or a KRAS, I might be inclined towards using tumor uninformed assays at that point. This is more in terms of not for molecular residual disease because they're already stage 4. But if, as I said before, if I have somebody who's limited stage, like 4 or 5 lesions in the liver, maybe 1 or 2 in the lung, I mean, not too much of a disease in the body, and our goal is to get to the resection, I think that would really help me in terms of how is the treatment response of the cancer cells in the blood and also on the scans to tie them up together and even make those decisions in terms of as a group together in our institution, whether surgery and then timing of surgery and the next steps.
Okay. You mentioned a 2 to 4 week wait time for testing after surgery. Is it the same time frame for radiation and ablations?
Good question. I think potentially I would wait for at least 2 weeks because there is a good shed rate as well after those procedures too. So after 2 weeks, I feel very comfortable after radiation or ablations.
Okay. And then is there a time that is too long to wait for the first ctDNA baseline testing to be completed?
Can you ask that question one more time? Sorry.
Is there a time that there a period of time that is too long to wait for the first ctDNA baseline?
So I mean, obviously, baseline 2 to 12 weeks is called the MRD window, molecular residual disease window. That's the window that we could identify whether there is presence of residual disease in the blood, yes or no, after surgery, right? Beyond that window, it becomes surveillance window, which is you are monitoring like a hawk what is the cancer cell burden in the blood doing. So those are the two different scenarios. If I have the chance and opportunity, I would like to get it within that 2 to 12 week window to help me and provide to my patient as well, the results of and potential of the prognosis implication, like if it's positive or negative, and then how do we monitor that moving forward.
Okay. For a stage 4 patient who is NED, is the Signatera test not as beneficial for recurrence monitoring?
Thanks, Catherine, for asking that question to clarify it. For a stage 4 patient who is no evidence of disease, I would be more inclined towards using Signatera because, and that's again, going back in the oligometastasis, let's say if we underwent treatment and we're able to resect and remove the tumor and we are monitoring it, and that would be the ideal scenario where I would like to monitor, Signatera testing to predict cancer recurrence back in the scans. Because this is something I tell my patients commonly as well, because these cancer cells are so small and they take time to reach a location like the GPS and build a home. Like if you look at it in Google Maps, in a neighborhood which is new and maybe new constructions, probably laying foundations, you may not see any home, but imagine those as cancer cells making some foundation there. You may not see it on the Google Maps like there, but until you go there in person, like in there and microscopically look at it, you may find it. But then as they build a home in liver or lung, that's when we can see it on the scan. But we have the ability to monitor that or even identify those ahead of the time using this testing in the blood. So for your scenario that you talked about, stage 4 NED, I think this would be an additional tool that I would like to use it for my patient together with scans and other tumor markers.
Okay, thank you. This is going to be my last question. I know we're at time. If the cancer it's not clear if the cancer is still active based on different procedures like ERCP, biopsy, CT scans. Can this test determine if the tumor is dead?
If the tumor is dead, if the scans also do not show evidence of cancer, is that what the question is? I mean, again, this is an evolution rather than one time. I usually am very cautious to my patients when I talk to them, hey, we have cured your cancer, right? I usually like to wait until 5 years for the guidelines or for what we have. But until then, got to be on the toes. Make sure we are testing this regularly. I mean, testing not just Signatera, not testing, monitoring our patients regularly, right? So until then, I may not feel comfortable using the words dead or cure, but if it is consistently negative over a period of time, my comfort level becomes higher in saying the risk of cancer coming back is low.
Perfect. Thank you so much. I know that we're a little after the hour. I appreciate you presenting today, Dr. Mala, and thank you for everyone who joined this webinar today.
Absolutely. My pleasure. Thanks so much. I mean, I think those are fantastic questions that motivate me always to come back. But thanks for the invitation and having me. Have a great rest of the day.